I'm going to talk about some principles of population health and population oral health. This first slide is a message from our sponsors, of course. Principles of public dental health, possibilities and challenges. I put that instrument on the screen because it's an indication of innovation of something long gone. It started its life as a key to a door. It ended its life as an extraction implement of teeth, and you can see the little hook there, if I get the end there, to extract teeth. So it's an innovation of sort that we're moving away from in dentistry, but I will pick up on this idea at the end about change and public health being all about change. How many of you know the story of the Broad Street pump? Show of hands. Hands going up all over the place. I'm not going to tell you the story, maybe at the end, but it's a really interesting story, and it's the basis for population health or public health, and it's the first demonstrated activity in public health that we have and we hold dear. Now this slide is going to turn up, or that picture is going to turn up throughout the presentation a number of times, and I'll buy a coffee for the person who can identify how many times it actually appears. And there's a reason for that, but we won't go into that either. The principles of population health recognises, and Deb has picked up on a number of these already, it recognises that there is an increasing gap between the rich and the poor, which underlies health disparity. This gap is increasing, and we're seeing it not only in health, but definitely in oral health. People who can afford or people who can access care have better services and have better health generally than those that can't. Public health also recognises now more than ever the importance of lifestyle and the factors that play into lifestyle. Diseases such as cancer and heart disease and dental caries are a mark of a particular lifestyle. The things that we do, our diet, whether we smoke, whether we don't, where we live, whether we have a fluoridated water supply. And the limitations that public health recognises, the limitations that we have as health providers to tackle chronic lifestyle diseases. These things are not simple. If they were simple, we would have solved them by now. But chronic lifestyle diseases are very difficult to solve. They're not just biology. You can't just give something, a magic something, and improve health when we're talking about population health, because so many other factors play into it. And we also recognise that the cost of healthcare is spiralling. And for oral health, for many people, it's spiraled out of their reach. And this is where public health activities, such as those provided by DHSV, come in. The characteristics of a population health approach, as some has been mentioned already by Deb, we understand that there are biological influences. We understand all about microbiology and bugs and how we can get disease by infection. But we also understand more and more the social determinants of health, which we're going to hear more about in the next presentation. Those things that go on around us all the time which influence our health. We recognise that health services must have equal emphasis on prevention and treatment. It's no good just providing things to fix people up, far too late. We need to be able to prevent disease in order that those things don't happen. There's another wonderful story, again, which I won't go into, about the ambulance in the valley or the fence around the cliff at the top. Prevention versus treatment. Public health has a concern for equity. We believe that people should be treated the same. We believe that they should have this access to appropriate care to the same degree. We understand that there is a role for other sectors in creating sustainable environments for health. In terms of dentistry, it's not just dentists, oral health therapists, prosthetists and so on, that are important in providing good oral health care. These things can expand into other areas of health. Obviously medicos, nurses and so on, but there's a whole range of other people, and Deb talked about models of care, and that's where we're going to be moving into in the future. The solution doesn't just lie with us. Of course, we have to have the participation of the community. Without the community participating, without them becoming actively involved, then we won't reach our goals of improving health. So it's not just us laying on the magic hands, it's getting the community to be involved as well. And there is a need for evidence-based policies and programs. Whatever we do has to have a good evidence behind it. We have to know that they work. We have to know that the science is sound and so on. And there has to be underpinning legislation and policy in many cases to make sure that people are not exposed to those things which will cause disease, or we at least limit those things. Risk minimisation. A good example of legislation, of course, in general public health is smoking, and smoking legislation, restaurants, the plain paper packaging of cigarettes and the wonderful photographs that turn up on cigarette packets. And we have one specifically for mouth and throat cancer. We know that some things work, but they only work if they are continually reinforced and that they're part of a wider program. This is a slide from early last century where school brush-ins were a feature, and this is at a school, obviously, and that was considered to be very important. Now, these things are still important in some way, but they will work only in collaboration or cooperation with other parts of public health programs. And Australia has a number of public health activities which are important or are singular to Australia. The Flying Doctor Service, which DHSV has a cooperation with to have a flying dental service or a van dental service, is one of a kind. It's been adopted by other countries to an extent, but it started in Australia. And we recognise it's so important that it's been put on one of our bills, $20 bills. John Flynn, who started the Flying Doctor Service, his face turns up on the $20 bill. That one. And of course, closing the gap activities, which Australia has had some success in, not full success, but is continuing to expand and to understand how some of these activities and programs can work in the Australian setting with the support of the community for which it's directed. So if we turn then to dental public health, picking up some of those concepts that we talked about in general public health. This is a definition which I'm sure you know and love, many of you. The science and art of preventing oral disease, promoting oral health, and improving the quality of life through the organised efforts of society, by Martin Downer. Now, often dental public health is used and population oral health is used, and sometimes community oral health. To me, they don't differ very much. They're just a fashion statement, if you like, changing some of the words around. But they are about this prevention of oral disease, which is an art, not necessarily just a science. It's a science, art and science. Promoting oral health, and it's about quality of life, not just survival, and the organised efforts of society. Again, without community participation, without the support of the community in what's happening, these things are bound to fail. So population oral health is a form of dental practice which serves the community as a patient rather than the individual. And again, this isn't a foreign concept. We, as clinicians, provide care to individual patients. But as public health practitioners, we're considering the whole population as our patient and providing care to that population. One of the best examples, of course, of population oral health is water fluoridation, something very dear to my heart. And Michael Smith was talking about it yesterday, the success that he's seeing already in Geelong, which has been fluoridated for a relatively short time, and the extent of the drop in dental caries in the preschool children. All capital cities, of course, in Australia are fluoridated, some longer than others. The first place to be fluoridated, which didn't have any legislation or policy behind it, was Beaconsfield in Tasmania. But Bacchus Marsh in Victoria wasn't long after that. Canberra was the first capital, and the others followed. It's a bit shaky in Brisbane. We're hearing all the time how the Brisbane state government have devolved responsibility down to the councils, and some councils have decided to withdraw fluoridation, which shows you how risky these public health activities can be unless there is strong support and strong policy supporting their implementation. This was a poster that came out in 1977 or 76 when the Melbourne was fluoridated. It had strong support across the board. This is an ADA poster, an ADA Vic Branch poster, which talks about the things that are still true with water fluoridation. It's effective, it's safe, and it's inexpensive. And here was a bipartisan support that was replicated just a few years ago with the rollout of water fluoridation in Victoria and in New South Wales, where DHSV, the University of Melbourne, Department of Health, and others, the ADA, came together and supported water fluoridation, and it became a reality. So here we are working in public dental health. Whether we're working in the Dental Hospital of Melbourne across the road or way out in the Northern Territory in Timber Creek, the sorts of diseases that we're looking at are pretty much the same. The communities are the same. They have the same expectations, the same desires, the same need for freedom of disease. So what are the hallmarks of population dental health services compared to private services? Now here I'm going to make a comparison. It's not meant to be a negative comparison. It's meant to provide some idea of what differentiates population dental services or public dental services from private dental services. As I said, we're dealing with largely the same sorts of diseases. Dental caries has been a scourge that's been with us for a long time. Periodontal diseases may even be increasing because of the fact that we're retaining our teeth longer than we ever have before, which is a good thing. And of course, we have rising levels of oral cancer being found. So if we look at the helicopter differences between public and private dental services, we can see that there are some differences. In the public dental sector, the goals are fairly much socially determined. That social determination is usually by government policy or direction. But there is an overarching policy which determines how services will be provided and who to, healthcare card holders and so on. We, as Deb said earlier, we want the best outcome for the maximum number, but we are limited by resources. It's not a bottomless bucket of money out there, as you well know, that we can provide services as we wish. There are selection processes through priority settings, and all of you have to deal with priority settings and who should be high priority and who should be of a lesser priority on the waiting list for care. And that selection for who gets care is made based on this priority setting. There are limited resources available, or limited alternatives available for patients. We can't provide in the public sector the full range of high-end dental services. They're just too expensive. If we hold to the best outcome for the maximum number of people, then we must realise that in order to do that, there has to be a limit on the complexity and the cost of the services that we're providing so that we can maximise the input or the output or the bang for the buck for the most number of people. And in the public sector, it could be described as institutionalised care and all that comes with it, the rules, the regulations, the controls, the things that we have to work with all the time, whether in a community health centre or in a larger dental hospital. These can be negative and positive, of course. They can direct us very closely to what we do, but some find it difficult to work under such tight controls as are necessary if we want to have the maximum number treated under the resources that we have. Compare that to the private sector, and I know there's some private practitioners among us here in the audience, which is a great thing. But in the private sector, the goals are coincidentally socially related. There isn't an overall strategy that we have for the private sector in providing care. We will follow the directions perhaps set in our dental associations or our oral health therapy associations, but there's not the social determination that we find in the public sector. The best outcome for each patient is determined by how much they are willing to pay, or how much their insurance company is willing to pay in the case of third parties. But it's not determined by, or not limited by, the provider's resources, it's limited by the recipient's resources. Self-selection by the patient of the practitioner is made for multiple reasons. They might like the dentist, they might like the oral health therapist, they might like the place where the provision of care is being provided, they might like the goldfish in the tank. But those are made for different reasons than in the public sector. There are multiple alternatives for patients, as you know. High-end services, implants that Deb mentioned before, which were a feature of the Congress just held a little while ago. Those patients can choose, provided they can pay, whatever they want to have within reason. And we can term that as a comparative to institutionalised care, non-institutionalised care. So controls are very much in the hands of the person providing the care, or in the practice or group practice or whatever it might be, not the large organisation that you have in the public sector. On the ground differences, for the public sector, there is limited control over care. There is control over the services that are provided. The waiting lists for care are often maintained through screening, and that's how priority is set. And screening is a very valuable tool in order to find out who needs the services first, who can wait a little longer, and who doesn't need care at all in the short to medium or even long term. The selection of the practitioner is made by the institution rather than the patient. There is often non-continuity in the practitioner, so if you have your course of care and you come back 6 months, 12 months, 2 years later, it's likely that you'll see someone else. There is limitations in the complexity of care, as I've said. The practitioner is responsible to the organisation rather than to the dental practice or to him or herself in providing care. And generally, the patients that are treated are low socioeconomic in nature. Not always, but generally. Compare that to the private, where there is full control over care by the patient. They can decide what they have and what they don't want. There is no waiting list generally for care. Now, that's not always true in the rural regions, I'm fully aware of that, where there are waiting lists for private and for public. But if you're looking at, in general terms, as a comparator to the public sector, there aren't the waiting lists of 400,000 or whatever people on public waiting lists in Australia in the private sector. The selection of practitioners is made by the patient. There is continuity in the practitioner. Generally, you know that if you go back to see the dentist in 12 months or 2 years, you're going to see the same one, or you can demand to see the same one as a patient. There are no limitations in the complexity of care offered, apart from the fact that from the patient's willingness to pay perspective. The practitioner is responsible to the patient rather than a larger organisation, and generally there are higher socioeconomic status patients seen in the private sector than in the public sector. Again, that's a truism perhaps, and certainly many lower socioeconomic patients do seek care in the private sector. But as a rule, when you compare the public with the private, you'll have a difference. There is a similarity in the quality of care, and I'm going to present some results in a moment of a study that was done in South Australia, which looked at this very thing, the comparative of comparing quality of care from one public compared to the private sector. Here's some more differences that I sat around and thought about between the public and the private sector. There are rules and regulations, funding, issues, control, management, teamwork is not an issue, it's a feature of the public sector compared to the private in general terms. And there is government interference, of course. When the government's providing the money, they will want to have some interference with how that money is spent. The private, you can see the comparisons there. I put in commercialism and fads and fashions because the private sector is far more likely to be exposed to greater commercialism and fads in dental care, the sorts of services that can be provided, and what's the thing of the moment to be, how that care is going to be provided. More and more in the private sector, third-party relationships are becoming important. And that's driving a lot of care, and there are ethical issues around how that care is provided if it's being pushed by a third party. See that? Differences between public and private. This is the study I was referring to by David Brennan a few years ago now from South Australia. He compared private and public patients. And he looked at satisfaction. He looked at a number of things, but he looked at satisfaction. And he found that there was no difference in overall satisfaction in the use of services when you look at the school dental service compared to private dental care. There were differences in quality and access and continuity, and in the private sector. In the public sector, there was greater satisfaction with the cost and the availability, but overall, the satisfaction was the same between the public and private. And patients in both had a similar attitude to dental health and visiting. We sometimes hear about how the public patients don't care about their oral health or don't care about the services. He found that there was no difference at all between what people expected in their health and what they expected in the services that were being provided. So public dental health activities change with changing technology and social values. There's no doubt that what we do changes. We had a key turned into an extraction implement. The activities will change from extraction through to prevention, the era that we're in now. And that's due largely to social value, of course, but also sometimes driven by the technology that's available. Things like fissure sealants that have become available since the 1970s and are readily used in both public and private. But the goals remain the same in public dentistry or population oral health. And that is to reduce the amount of disease, premature tooth loss, and disease-produced discomfort and disability in the population. That's what we're here to do, to reduce the amount of disease, to improve the quality of health, quality of life in providing the services that we provide in the public sector. So we do need to embrace change. Things will change, there's no doubt about it. What are the sorts of things that will drive change? Well, here's a list of things, but you may quite easily add to those. Patterns of disease are changing, clearly. I'm not seeing the sorts of disease that my grandfather was seeing as a dentist in the early part of last century. The ageing of the population. We're living longer, and we're living longer with teeth. We've never had to face the problem that we have today with people in nursing homes or aged care facilities with their own teeth. It was relatively easy to look after dentures in the nursing home, provided you didn't take them all out, put them in a bucket, and clean them, which is what I've heard happened, and no one knew quite who owned them. But natural teeth are difficult to look after in nursing homes. Difficult for people who don't have the dexterity, and difficult for the carers who aren't necessarily interested in the service they provide. I'm getting the wrap up, so I will wrap up. And those are the other things there: increasing gaps between the rich and poor, cost of health care, public outrage over access to care, models of care, which Deb has mentioned, and increasing evidence of what works and what doesn't. A couple of pithy quotes which I got from the internet late last night. Nothing ever changed, there'll be no butterflies, and change is inevitable except from a vending machine. Take it as you will. We do have a plan. It is about to be changed, and that plan will pick up things that have worked and things that haven't worked and what we need to do more about. There's the pump again, if you're counting. The change that we have is not going to be fast. We sometimes see very quick things, like the handle of the Broad Street pump being taken off and people stopping the cholera epidemic being slowed. But change generally in public health doesn't happen quickly. We do have an opportunity now to make a change with the $85 million that's coming our way, and hopefully the additional money next year. That will drive change. It'll drive the models of care, it'll change what we do in the public sector for the better. We have to make it work. And I think that's all. Thank you very much.